Thanks. Thank you to Dr. Force and Dr. Lieberman for the invitation to speak here today. Just want to say it's been a tremendous session. I think the talks have been excellent. So we're going to take a step backwards to a workup, and my task is to talk a little bit about management of the anterior mediastinal mass. So no disclosures. I want to try to make this really sort of simple and as practical as possible. So just to start out, what is the actual prevalence of anterior mediastinal masses? Well, we have some data about that actually from the Framingham Heart Study. So there was 2,500 patients who got CT scans, coronary CT scans, and the investigators went back to look at all of those scans in this patient population. So out of 2,500 plus CT scans, there were 23 of those patients who were found to have an anterior mediastinal mass. So just about 1% of the population was found to have an anterior mediastinal mass. Now, so take a look at this. You walk in the clinic and this is your next patient. What are you going to do with this? And is what you're going to do with this different from this patient? How about this patient? Should this be treated differently than this? Or this mass that seems to be encasing the right ventricular outflow tract? How do you approach these? So, the laundry list of the differential diagnosis is long, but it involves mostly thymic neoplasms, germ cell tumors, lymphomas, but also many benign lesions, thymolipomas, Castleman's disease, cysts, and thyroid. So how do you start to pare this down? Well, what are your options, first of all? In the order of invasiveness, you can observe, you can image it further, you can biopsy it, or you can take it out. I kind of like to think of things in terms of small lesions versus large lesions, is sort of how I categorize them. So let's start with this patient again. This was a 60-year-old asymptomatic female that comes in with this lesion. It's a solid lesion, it's well encapsulated, doesn't seem to be any radiographic suspicion of invasion. Some heterogeneity in it on the CT scan. There's a little bit of a cystic component. So a decision was made here to resect. Simple, pretty simple and straightforward. Did a minimally invasive thymectomy, a complete resection. Pathology was a thymoma type AB. Pretty straightforward. Now what about this patient? 29-year-old male who was found to have recent weight loss. And part of the workup, they did this scan. Again, observe, image, biopsy, or resect. Well, the last patient, we just went ahead and went straight to surgery and took it out. But what is the prevalence of a non-therapeutic thymectomy, i.e. doing a surgery where you didn't necessarily need to? Well, Mike Kent and the group at the BI Deaconess took a look, and this is probably the largest look at this question, using the nationwide inpatient sample, the NIS. It contained 1,300 thymectomies over a 10-year period, and when they went and looked at it, 28%, over a quarter of these surgeries that were done were considered non-therapeutic, meaning that they took out benign lesions or lymphomas, and there was absolutely no therapeutic benefit for the patient whatsoever. Interestingly, of those non-therapeutic thymectomies, almost half of them were for thymic hyperplasia. And I thought even more interesting was that almost 3/4 of those non-therapeutic thymectomies were done open with sternotomies. So interestingly, this patient that we were just talking about, this 29-year-old, did see a surgeon and was offered a sternotomy and a thymectomy. And he didn't like that idea, so he came to see us. Well, he had a 20-pound weight loss in 3 months. He's a young male. They sent some tumor markers, and those were negative. They did also do some thyroid function tests given his weight loss, and it turned out that he had Graves' disease. Well, there is actually a known association between Graves' disease and thymic hyperplasia, so based on that, we elected to observe. And this is him again, and you can see now, actually, if you look at the CT scan, you can actually make out sort of the lobes of the thymus gland. It has the typical triangular shape. And after 3 months of treatment for his Graves' disease, you can see that the mass is gone. So this was thymic hyperplasia. Now, are there other things that you can do to help you sort out this decision? Well, there's certainly some diagnostic imaging adjuncts that you can employ. The radiologists at our group took a look at how we might better distinguish benign lesions from malignancy on CT scan, and looking at over 60 resected patients with either benign disease or early stage thymic neoplasms. The characteristics that sort of panned out that were more associated with benign pathology were a triangular thymic shape, any presence of fat within the lesion, midline location as opposed to lateral, absence of infiltration of the surrounding fat, and smaller size. But sometimes that alone still leaves you on the fence. And so if there's a possibility you think that there might be something benign, MRI actually can be helpful for helping sort this out. And this predominantly depends on the ability to look at the different chemical shift in MRI. So I want you to focus, the upper half is the CT scan and the bottom half is the corresponding MRI. So again, this patient has the classic triangular shaped thymus. Here on this left-hand side of the MRI, this is the in-phase sequence, and you can see it's bright, it enhances. And on the opposed phase, it does not enhance. So there's a change there in the shift. This is consistent with hyperplasia. Now here's another triangular shaped lesion, but this one actually there's no difference in the phases, and this turns out to be a thymoma. How about a round mass? Well, so this is a little bit more suspicious. Here's the CT, here's the MRI again. Again, no difference in the phase, in phase or opposed phase, the same level of enhancement. This was a thymoma. But here's a rounded lesion, and actually there's a differential in the enhancement, here bright on the in phase and dark on the opposed phase. And since they were still suspicious given the morphology of it, they took it out. And lo and behold, it was thymic hyperplasia. These are the lymphoid follicles in a normal thymus. So MRI can be helpful, I think, in particular if you think that there's something that might be benign. So let's shift to the big lesions. So here's this woman, 79-year-old woman, who presented initially with cough and dyspnea. What would you do with this patient? Well, you know, we had this long laundry list in the beginning, but once you start getting the big things, I think the list starts to shrink down to mostly malignant type etiologies. So thymic tumors, lymphoma, germ cell tumors. So this woman, she saw a surgeon and went through the options, observe, image, biopsy, or resect. So this surgeon elected to biopsy, or I should say resect, because they did a left VATS, and reading through the operative note, they encountered a large mass, ultimately found to be unresectable. Partial debulking was undertaken, removing most of the tumor. This was the pathology, thymoma type A. And you can see the post-resection, post-surgical CT scan that there's quite a fair amount of tumor left. So this is probably about the worst thing that could have happened to this patient. Pleural metastases, pleural recurrence is probably the most likely place for these tumors to recur, and now this patient has been successfully had tumor spread throughout her pleural space in the course of this VATS. So the considerations for how you decide to biopsy and resect are severalfold. Obviously, if you're going to resect, the primary goal of resection is complete RO0 resection. That is the main goal, the only goal, I would say. So you need to select your surgical approach accordingly. And minimizing invasiveness is really secondary to the completeness of resection. And that may be different in different surgeons' hands, but again, if you're going to resect, the goal is complete RO0 resection. On the other hand, if you choose to biopsy, the whole goal is diagnosis, however it takes to make sure you get the diagnosis and get the diagnosis on the first shot. But the secondary issue to consider is what are the potential resulting consequences of your method of biopsying this. So perhaps they set out to try to biopsy this lesion with VATS initially, and that might have been fine if it was lymphoma, but if there's a chance it was a thymoma, and where you wouldn't want to disrupt or violate the tumor, then you need to think about that. So how about this young woman, 20-year-old female with chest pain? May not be immediately apparent that it's resectable, so she underwent a biopsy. Now you can do an FNA, you can do a core biopsy. What's the difference? Or you could do a surgical biopsy. You could do a Chamberlain, you could do a VATS. Well, in fact, so many people shy away from FNA because the mantra is always to get more tissue, but in fact, FNA is successful and can diagnose mediastinal tumors, and these are micrographs showing thymic neoplasms based on cytology. And there is data comparing the accuracy rates of fine needle aspiration versus core biopsy, true cut biopsies. And in fact, the sensitivity and specificity for both are actually both quite good. The accuracy for these is good in diagnosing both carcinomas, lymphomas, as well as thymomas. But since this is a talk about best practices, there are guidelines here to follow, and this is something put out by the International Thymic Malignancy Interest Group, ITMIG. So if you're going to do an FNA, ideally you have the ability to do rapid on-site evaluation to assess your specimen. You want to take multiple passes to additionally be able to send for cell block and send in cytolite or similar solution. And if you do think that you're going to have lymphoma here, then it's important that you take additional passes for flow cytometry, and those specimens, those passes need to be put in RPMI. This is for somebody who's going a CT-guided biopsy, FNA, and it would apply if you were doing a bronchoscopy or an EBUS. Now, EBUS isn't really pertinent here because that's not something that you would approach the anterior mediastinum with. But in any case, you want to follow these principles if you're doing an FNA, and you want to take multiple passes because you want to be able to send stuff for cell block as well as flow cytometry. Core biopsies, you want to have a large gauge needle, 19 gauge or larger. And then surgical biopsies, you know, some pitfalls, we always think like, well, we should check and make sure we got diagnostic tissue and send it frozen. And so you go and take a lot of biopsies, and send it for frozen. But don't send all of it, because as soon as you send it to frozen, it's gone. You can't send that for a flow cytometry anymore. You can't do anything with that. Be careful about sending off that specimen, you know, reserving stuff aside so that that can be sent for flow cytometry and to do all the other immunohistochemical studies that you need to do. For flow cytometry alone, they recommend having at least 1 to 2 cubic centimeters of tissue. So this young woman underwent a core biopsy, and this was a diffuse large B-cell lymphoma. Now, interestingly, after treatment, her mass shrunk, but she still had a residual PET-positive mass. So now what? Well, we could biopsy it, core biopsy it again, but I think the risk of having a negative, false negative result would be pretty high in this setting. So here we elected to follow up with a Chamberlain procedure, took out the second intercostal cartilage, and got some good biopsies of the mass. Ultimately, the pathology showed just necrosis and treated lymphoma, and she's now NAD for 8 years. And finally, this gentleman, 58-year-old man who fell, got an x-ray, found a mass, and then ended up with a CT scan showing this mass encasing the PA. Well, he also got a core biopsy, and this was a seminoma. Again, not something that he needed to have surgery for. I'll just close with this about the risk of seeding with needle biopsies, because patients ask about this all the time. So there are a few case reports about needle biopsy seeding. Here's one you can see 5 months after core biopsy. Here's another one 12 years after a core biopsy. And this is an old report where they didn't have images from the scans, but this is the pathology, 4 months after the core needle biopsy. So can it happen? Yes, there have been a few reports. But if you take from the data from lung cancer, the risk of this in arguably a much more aggressive disease is very small, less than 1% in one series, 0.02% of biopsies in another series. Thymic neoplasms are arguably less aggressive. I think you can extrapolate that the risk of that is even lower. So I'll just summarize the approach to the anterior mediastinal mass. I think it's useful to think about in small lesion versus large lesion. Your options are observe, image, biopsy, or resect. If it's a small lesion, really it boils down to whether you want to observe this or resect it. And if you think that it might be benign, it may be helpful to consider additional imaging, in particular MRI. If it's a big lesion, I think your options really boil down to, should I biopsy this or resect it? And I think a thoughtful selection of your biopsy strategy and technique and ensuring that you handle your specimen properly is critical. And if you choose to go straight to surgery, obviously your goal is a complete or reserve resection. I'll just finish with a plug for the ITMIG meeting coming up this summer, International Thymic Malignancy Interest Group, 8th Annual Conference, which will be in September in Torino, Italy. Anybody who's interested, would love to see you there. Thanks a lot.